Thank you for each of you that's joined us for this event. And I think I want to focus on the importance of knowledge in managing this disease. Uh, the knowledge you have will give you hope that you can control the symptoms, you can restore your life. But the key is identifying the proper way um, I, to to do that, to manage the disease. And we hope to give you some information and help guide your journey through this process. And it's really not a long process. If you learn the concepts, identify the appropriate way to move forward, you can get these things under control in an efficient and effective and safe manner. Before we go any further, just to give you a little background about who I am, um, and how I got here. After finishing my ophthalmology residency, so I'm a medical physician, I'm a medical doctor, went to medical school at St. Louis University. After residency, I focused on cornea and ocular surface disease with a 3-year fellowship. My 3 years were focusing on ocular surface disease and cornea external diseases. During my fellowship, I developed, I had an interest in Meibomian glands, and I actually grew them.
Okay,
And
I
Claire's going to put
see
up
your
a little
question.
slide of uh, from one of my initial papers showing an isolated rabbit meibomian gland, as you can see here, uh, and on the right. So these whole gland cultures, or these whole glands, rabbit meibomian glands, are isolated and cultured. I further went to isolate ductal elements separate from acinar elements and cultured each in a what's called a clonal growth. So we're focusing on each system of the gland. The gland, as we may get into a little later, and I don't want to go too deep right now, but suffice it to say that I was looking at the modulation of the proliferation of the two cell lines of the meibomian gland using growth factors. Well, that was back in 1988 to 1991. I had no idea at the time that 15 years later, I would develop this or invent and develop this procedure called Meibomian gland probing to have helped so many patients, thousands of patients already since the mid 2000s when I started offering this procedure. I learned about its effectiveness and started offering the procedure. So uh, it's I come at this disease, dry eye and ocular surface disease, from that background. Um, where initially I would do corneal transplants and reconstruct eyes. The finding and understanding of how to successfully manage my Bowman gland dysfunction and dry eye led me to this invention, this discovery, from which once that was established, then the demand for my services grew to the point where I had to give up the other aspects of my specialty and really focus on this disease. And the reason, of course, is because it works. The way I manage and approach this disease works. And so my research has focused exclusively in this area. Let's move on, not spend any
Yeah,
more
yeah.
time on me. Let's move forward on addressing some of these basic concepts that are important to understand, and then we're going to move on to diagnostic tests and answer questions.
Yeah, so what we're trying to do tonight is to talk about the testing. And because when I speak with people on the Facebook site, nobody really understands what the testing is and what comorbidities are and how important the testing is. So I know there is a fundamental knowledge we need to establish prior to getting into these questions. So, Dr. Mass, can you talk about what comorbidities are and why they're so important?
Okay. So when we think about, and Claire's going to put up an illustration here. When we think about controlling ocular surface disease or symptoms of ocular surface disease, we have to be able to identify the root cause of those symptoms. And the root cause of those symptoms can be understood when we realize that the meibomian gland dysfunction typically accounts or is the major factor in over 85% of these cases of irritated eyes and dry eyes. Uh, but we cannot focus exclusively on the Meibomian gland because the Meibomian gland health is reliant upon these what's called comorbidities or other diseases that would lead to inflammation to cause the meibomian glands to not function. And specifically, the inflammation causes the periductal fibrosis or scar tissue that develops around the duct wall and pinches it in or like a tight belt. And you'll see evidence of that later in the presentation. So the comorbidities, and as we see here in this illustration of the hub and wheel, the position in the onset and progression of this disease is located at the hub of this wheel. But each spoke in this wheel is a comorbidity, which if left undiagnosed or inadequately treated, will lead to inflammation that will initiate or exacerbate the meibomian gland disease. So it's important not just to focus on meibomian gland disease. Some patients, try to make an appointment just to come and get probed to restore the integrity of the gland. That's not the answer. That's the beginning of the answer, but we have to identify the comorbid diseases and treat them as well. Otherwise, the results of probing will be relatively short-lived, typically about 2 or 3 months, rather than a year. You should not, if you identify and treat your comorbidities, you're typically probed annually. If not, then it's more frequent. So without getting into specific comorbidities, we can move on to the next concept.
Yeah. So, and just to summarize that, what I took from that is a comorbidity is multiple diseases all happening at the same time within your eye.
Right.
Right.
And it could be also a system. Yeah, I mean, it could be systemic disease with impact on the ocular surface in the eye as well. That's right.
All right. And all right. So, and how do you explain scar tissue?
Um, scar tissue in this case occurs around the duct wall. So, and this was the aha moment I had in the mid 2000s when I had a middle-aged man who was suffering greatly uh, in pain, but yet he was able to make watery tear. So I had developed a prototype to try and understand this disease. I concluded I needed to go in and maybe find a way to get inside the gland and maybe learn something to help patients that were suffering despite the conventional treatments. Conventional treatments being lid hygiene, like warm compresses, lid scrubs, as well as steroid medication, antibiotic medication. So many patients, these approaches, traditional approaches, were not working. So I decided maybe the answer lay inside the gland. Developed a prototype probe. The first patient had tried everything, had been everywhere. He agreed to let me, insert the probe through the natural orifice of the gland. And what I found was rather than thick meibum, I found fixed resistance. And this was a completely new concept. No one talked about at the time, the mid 2000s, about fixed resistance inside of a gland. As I passed the probe, the wire probe into the gland, it would not progress. I would have to give extra energy. And when I did, there was a discernible pop, and oil flowed. The meibum flowed along the wire probe, exiting the orifice. And with that, the patient felt better and asked me to probe other glands. By the time we finished his lower lid, he was so happy. He asked me to do the other lids, and I did. And he jumped out of the chair and hugged me. This was something that he had been waiting for. He'd been suffering for so long, and just like that, it turned his life around. For me as well, for that matter, because again, with that aha moment, not only did I realize that probing was diagnostic, but also therapeutic. With further research, it turned out to be that fixed resistance was from scar tissue. And again, like a tourniquet wrapped around the duct. So I think Claire's going to put up another figure. This is from a published article in 2019 where we show the periductal fibrosis. Is there a way to enlarge that, Claire? Thank you. That's better. Yeah, perfect. So in A, the open arrowhead is pointing to the lumen, or that channel through which the oil will flow. It's surrounded by the duct wall comprised of epithelium. The arrow at 12 o'clock, or more like 12:30 to 1 o'clock, that arrow, and at 3 o'clock, that star, those indicate sheets of scar tissue at 12 o'clock and 3 o'clock. Now, as we go deeper, and I should comment, these are images from confocal microscopy. So again, we're going to talk later about diagnostics and confocal microscopy. Here's a beautiful example of the importance and helpfulness of confocal microscopy, which I use on the Meibomian gland lid margin. I find it very helpful, very effective, and yields a lot of significant diagnostic information. In B, as we travel deeper into the gland, it's the same gland as A, we find that the scar tissue is now organized as a tight belt encircling the gland and choking off the gland. You can see how the lumen is now collapsing. We can see in letter C, image in C at 4 o'clock, again, an area of scar tissue pinching in on the duct wall. So the next slide, we're going to show a graphic display of what this means when you have this periductal fibrosis. And by the way, everyone that's listening out there, we have about 40 people right now. Feel free to inquire, send us questions along the way. So in this case, we have the healthy gland. You can see on top left of this illustration, and I like to go actually down below it where it says CDO, complete distal obstruction. And in complete distal obstruction, that's characterized by a ring of scar tissue, as Claire is going to encircle in red. That ring of scar tissue is choking off the flow of the oil. Now notice where it's positioned. It's positioned just inside the orifice, and maybe put a dot on the orifice, Claire. That oval right there, that's the orifice. So the oil would normally go through the orifice. It would come from the acini. So we're going to put arrows all the way from each acini. That's right, down. It would come and right through that orifice and out into the tear film, but for that scar tissue. So the scar tissue blocks that, and what happens is the pressure builds up inside of that gland, and if we don't release the scar tissue, then high pressure will ultimately, well, first it causes cystic changes in the acini. So the acini will develop the cystic deformity. Well, it'll bulge outward, and that's what we show in the middle image on the lower row. But ultimately, the gland will undergo a trophic change, and you can see the bottom right, whole gland atrophy, where there's a trophic change. Now, it's also important to note that when we made this illustration, we left the orifice intact. And again, Claire's going to put it right there. That's important because, as we'll see later on, the fact that the orifice intact means that gland should be probed. So if your doctor does a Meibography on you and there's whole gland atrophy and there's no gland tissue visible on Meibography, yet there is an orifice there, that gland should be probed. Why? Because, and I published this, I think also in 219 or 220, but if there's an orifice there, then there's a duct there. There still may be the periductal fibrosis, which can be released by the scar tissue. But if there is an orifice there, there's a duct. And if there's a duct there, that means there may be residual, and often is, residual acinar epithelium, which can be stimulated by the probing action and to develop some functionality. So in other words, you can get these glands to synthesize and secrete oil, even though you can't see sufficient numbers of acinar epithelium on Meibography. Important point.
Let me interrupt for a second.
Yes.
So many times I see on all of the sites people saying their doctor has told them that their glands are getting clogged and they need to clear their glands. And what I think the biggest misconception is that people don't understand that it's actually on the outside of the central duct, right?
So, right.
It's
The
not
scar
clogging
tissue.
inside. There's not a piece of hardened meibum or something inside the gland that's clogging these. It's outside strangling them.
So the scar tissue, it chokes off the flow, so there's trapped meibum behind the scar tissue. And so it's important to release that scar tissue. And I find that is the the cause of 90% of glands, over 90% of glands and lids with MGD have this fixed resistance, over 90%. You can have thickened oil, absolutely, but again, that thickened oil is as a cause of obstruction is relatively less frequent. Again, 90% of glands in lids with MGD have periductal fibrosis. Therefore, I recommend probing in all patients because it's ubiquitous.
Somebody had asked here that says, how do you differentiate scar tissue from hyperkeratinization?
Well, hyperkeratinization does not provide a fixed resistance that scar tissue provides. So, hyperkeratinization is basically excess cells being sloughed off into the lumen. But those are individual cells. It's not going to give you a solid fixed resistance. So again, because the fixed resistance of periductal fibrosis is so common, it's essential to, in my view, it's essential to probe once you've been diagnosed with MGD. For people that don't have access to probing, then I recommend focusing on your comorbidities to minimize the extent of your periductal fibrosis, uh, and ultimately, again, recommend when available, when accessible, to go ahead and have your glands probed.
All right, what exactly is probing doing to the Meibomian gland?
Well, before I just want to one point, Matt, if I can, before we move on to
Of
that
course.
question. I want to go. Claire's got the slide up, and I want to go back to the normal and make the point that to the middle image on the upper tier, upper row is CPO. What that means is complete proximal obstruction. There, the scar tissue, the periductal fibrosis, is deeper in the gland. Now that's important because that scar tissue is now behind at least one acidoductal unit, as Claire's pointing out. Therefore, if your doctor presses over that gland and looks for expressibility, he's going to find that yes, oil can flow out, but that's a red herring. That's a red herring. That's not a healthy gland. That's seemingly healthy. In that case, the scar tissue is deeper, and the entire rest of the gland behind that scar tissue will be exposed to high pressure. And that high pressure, just like we saw earlier when the entire gland was exposed to high pressure, that high pressure will cause the tissue behind that scar to undergo a trophic change. And then you're left with a small truncated gland. That's an important concept. I've been talking about that again since the mid 2000s, but again, it's important to understand that just because you have expressible glands, recognize that 90% of glands in lids with MGD have scar tissue somewhere along the length of the gland. So it's a very important point. You don't want to lose the proximal piece of your gland because, again, it wasn't addressed. This scar tissue wasn't addressed. Now, to your question, Matt, what exactly does probing do for the Meibomian gland? And for that, we need to move to another slide. And Claire's going to show us this other slide. We've got to erase that. We got to erase that material. Okay. So thank you, Claire. So this A and B shows the effect of probing on increasing growth of meibomian gland tissue. This is from a retrospective study we published in 2018. And 40% of 40% of lids that have been probed with MGD, we find increased gland tissue. And this is one example. Inside that oval, you can see increased gland tissue. Now, what's happening at a cellular level is shown in C and D. So here we see this is in C and D, and again, and we should take a step back because since we're talking diagnostics, A and B is a meibography. All right, it's an infrared meibography. We do video meibography here because you're able to identify any artifact that you might have if you just simply held the lid in a single position, take a snapshot. Depending upon how the lid is held, you can actually introduce artifact. And I published a paper where we found that focusing on the upper lid to perform meibography is actually the better, more accurate way to evaluate changes in the meibomian glands over time if you're like just trying to evaluate a therapy. And this is the article that was published in 2018. And Claire will show the next slide just to show one image here, just to give you an idea. This is, again, lower lid meibography, which, again, in my experience, has associated with it inaccuracies and artifact. This is one example. Not only is the way you hold the lid can affect the result or the appearance of the meibomian gland, but how the patient looks. So in left column left, it's up gaze, and column right is primary, means straight ahead. And you can see how in up gaze, it shows the entire lid, the width of the lid is significantly greater when the patient's looking up than when they're looking straight ahead. So as a percentage of the entire lid, in primary gaze, when you look straight ahead, the glands look to be more full or longer than in up gaze. This is the same lid, mind you. This is the same lid, but you can see how the way the patient looks can distort or create a misleading reading. So if you're evaluating therapy again, and you begin the therapy with, say, and you take images of you looking up gaze, and then after a month, repeat images are taken of your meibomian glands in the lower lid, and you're looking straight ahead. One might say, "Oh, look, congratulations, your glands have lengthened," when it's not the case. Just to make that point, very important. So when we go back, and this is statistically significant, our results. So we're going to go back to here. So in C and D, we have, again, the confocal microscopy. And here we showed earlier how the confocal microscopy can show scar tissue. Here we show how the confocal microscopy can show increased duct wall thickness. And this is a very exciting result. And we published a paper last year showing statistically significant increased duct wall thickness after probing. This is one example here where we show the same thing. Notice in C from 6 o'clock to about 10 o'clock, the flattening of that border of the meibomian gland orifice. And notice how after probing in D, how it rounds up. You can also appreciate, without us showing any quantification, you can see the increased duct wall thickness. And then the next slide is going to actually show the images from the article, and we're going to increase that size of that so it can be appreciated. In A, thank you, Claire. In A, pre-MGP, so pre-probing, you can see the flat edges of the meibomian gland from periductal fibrosis. And 2 weeks later, look at how that orifice is rounded up. So release the scar tissue, the orifice rounds up like that, and there's a 25% increase in duct wall thickness, statistically significant. But in addition to that, what's also exciting is the lumen, the area of the lumen, that channel that the oil flows through. Okay, that is increased, that's dilated, over 75%. That means that there's a greater capacity to bring that oil through the duct, through the gland, and the orifice into the tear film. So there's increased duct wall thickness, which means increased functionality, and then there's also an increased ability to deliver the oil to the tear film. We measured at 2 different sites along the distal duct, both distal and proximal, and the other thing we'd like to review in C, we show that the peak over the course of a year, the peak results occur between 1 and 3 months. This is after probing. Between 1 and 3 months is the peak results, and then it gradually tapers off to, at the end of a year, it's still above baseline. But it's important to note that again, this the result of increased functionality, increased duct wall thickness, increased functionality correlate with improved symptoms we call accept lid tenderness. So that's burning, stinging, photophobia due to the increased functionality of the gland. And here we show on the graphic display the excluding lid tenderness in blue. Okay, by 3 months it reaches its peak. This is a graph showing visual. It's called a visual analog scale. But basically, as the numbers increase, that means the patient is feeling more and more comfortable, symptom free. Notice that in comparison to the blue graph, excluding lid tenderness, the red has a rapid increase in comfort. The red meaning lid tenderness. A rapid increase in comfort. Why? Because lid tenderness correlates with the mechanical blockage inside the gland. The intraductal pressure that is mechanical in nature due to the fibrosis, which is relieved immediately as we release the scar tissue with probing. So we have that immediate improvement in comfort, and that's a wow effect on patients that have been suffering for so long with tender lids. And sometimes they don't even know they have tender lids. They just don't let anybody near their lids or touch their lids themselves, and that's relieved immediately, which is what that first patient actually presented with, patient 0, I mentioned earlier in today. So 2 different types of symptoms, 2 different types of therapeutic responses, depending if it's lid tenderness or excluding lid tenderness. Some patients have both lid tenderness and other symptoms as well, excluding lid tenderness. But this is fascinating how these clinical results, and these I've had for many, many years, how they correlate to our new findings with confocal microscopy, showing the maximum peak increase in duct wall thickness and increase in lumen area at that juncture, the 1 to 3 month juncture.
All right.
A lot of information. I'm trying to get a lot of information, and maybe it's too much information, but
No, it's it's good stuff. It's just it's not always easy to follow, but it's good medical stuff. Let's talk about. I see a lot of propaganda out there saying on how probing is destructive to the meibomian glands and it causes scar tissue and it's no good for you. And I can't tell you how many times I talk to people where their doctors have instructed them, no, don't get probed because it's going to ruin your glands. Over your 25 years of this, have you ever found anything?
no, not at all. And Claire, if you have access to that video where we show the release of the upon release of the fibrosis, the trapped meibomian gland contents are able to access the orifice tracking along the wire pro. If you have that, let's pull it up, and maybe before the end of the Q&A, we can show that. That's also a very important demonstration to see. But to your question, no, actually, it's like an impacted bowel. If my patient had an impacted bowel, the solution is to release the impaction. So I release the scar tissue that may be wrapped around an intestine. Maybe the patient had a previous C-section, for example, or whatever. Rather than living your life having to be on liquid diet because your intestine has been choked off or reduced capacity for outflow, I'd rather release the scar tissue and have a normal functioning intestine. So that's what probing does. Same analogy you can say for esophageal strictures. Sometimes we can get strictures around our esophagus that reduce the opening of the esophagus. Sometimes the urinary tract system, again, strictures. So in this case, the meibomian glands, if we can release that scar tissue that's choking off the gland, then the gland can restore to normal functionality. We just showed on confocal microscopy how the probing actually activates the gland stem cell, leading to a robust proliferation of epithelial cells and increased gland functionality. I mean, here we have, it's beautiful how it can actually stimulate the gland stem cells. This is what we're looking for. and we're successfully able to do so. So
Yeah,
I
that's
don't, I see it all positive.
yeah, that's another thing. The activation that people will always have conflicting results on. They say, oh, they can't regenerate themselves, but you've proven that.
Exactly. We show that, and we show also increased gland tissue at Meibography. We are now focused research on um, taking those results and even further growing those results, even further demonstrating further growth to where we can actually restore the normal healthy population of Meibomian glands within a lid.
At times, patients complain that they're not feeling better after being probed. Can we touch on that a little bit?
If patients aren't feeling better after they're probed, it's because with a normal probing procedure, it's important to identify those comorbidities. So the patient has ongoing or maybe um, ongoing symptoms or improved symptoms that then relapse. There are comorbidities that have not been adequately identified and adequately treated. So it's very important to identify those comorbidities um, and to treat those as well with very targeted therapy. That's the other thing. It's important to not play shotgun with this disease. Patients come here, they've been suffering for so long. We identify the comorbidities, we identify the severity of the meibomian gland dysfunction, and we target the MGD with probing. We target the comorbidities with specific therapies, and this is how we get the disease under control and restore comfort rapidly. Um, it's important to be efficient in treatment, to not again use a number of these questionable therapies that are again it's non-specific and not targeted to that specific or those specific comorbidities. You can save a lot of time and financially finances as well by being very focused and targeted in the therapies that you receive.
And
So
that's what that's what we're trying to do is discuss the different testing, and that's really what this is about tonight. Because so many times that I talk to people on different times at different sites, is they don't know what the testing is. They don't understand what the testing is. And I have somebody who just came in live with a question, and exact. There's a couple of these. It says, how do you determine what your comorbidities are? For decades now, various eye doctors have prescribed different things to see what works, and nothing has. And she says, I've had probing. Uh,
that's yeah, and so the answer is if you've had probing and you're still having issues, again, there are comorbidities. So you need to have follow-up. Um, if a patient comes here and we probe them, we identify comorbidities, and 3 months later they say they're having problems, it's either, well, sometimes the key is follow-up. So they need to reach out to me and say they have ongoing issues, in which case we need to identify what therapies they're doing. What are they still doing? Are they compliant in their medications? Are they compliant in their treatments? Did we address all comorbidities? Did they say, no, I don't want to do resurfacing? If maybe they have symptomatic chalasis, maybe they don't want to do it. Maybe they were told that they don't have symptomatic chalasis. So the reason why someone may have ongoing symptoms is one, lack of follow-up, two, non-compliant, three, did not manage all their comorbidities or did not follow through with all their comorbidities. The fourth possibility is there may be other comorbidities that developed and they need to be identified and treated. But there's a reason. There's a reason, and the key is follow-up, really, because if you have good follow-up, that enables us to deal with and reverse the other issues: new comorbidity, lack of proceeding on with recommended procedures, or being non-compliant. Sometimes patients don't even know they're non-compliant, and so we have to review. Yeah, we have to review everything in great detail to identify, and then there's a oops from the patient. Yeah, didn't realize I was supposed to do that. So sometimes, again, it's this is so much information, which is great, Matt, that you're doing this because this allows us to convey information to people that are in need of help, so that when they go to their own doctors, come here, but they have some information, they can speak to, they know the vocabulary, and they're already way ahead of finding relief for themselves because they understand the concept, the essential concepts behind this disease.
And just a little story, I was struggling real bad, and at one of my points, I had a flare up and couldn't figure out why. And I went down to see Dr. Maskin, and he said, "Well, what are you doing? Are you taking your pad a day, twice a day?" And I said, "No, I don't want to take pad a day. I don't have ocular allergies." And he said, "Well, I don't understand why you're not taking it, because I know for a fact you have ocular allergies." And I said, "Oh, all right, maybe I do, I guess." And I started taking my pad a day, and it would turn me around, turn me back to my normal. It's like, well, he
See,
was right,
and
and
that's
I didn't
and
even
that's
know.
and that's the key. It's so important to have the communication or be willing to communicate with your physician. And you have to have that open lines of communication where sometimes the missing link can be identified in an email, sometimes not, maybe sometimes a Zoom follow-up, or sometimes maybe in person. But again, there should ultimately these symptoms should be brought under control in a fairly rapid way and should keep them under control. Knowing the concepts helps you get to that point.
Okay. Um, do we want to touch on so tonight we want to talk about infrared meibography, and we want to talk about the confocal microscopy, what they are, how to use them, how you use them, how you implement them into your protocol with your testing. So,
Okay. So let's go to the next slide. Okay, so here we're performing infrared mammography on, um, actually, this is one of my staff members. And the right part of that slide is the result, is the mammography. Now, uh, we can see here, there's a lot of information here, but ultimately we're just going to focus on a few points. Claire, if you're able to zoom in on the mammography, that would be great. Of course, this is an upper, thank you. There's an upper lid, and we see areas of atrophy in the center, right? So we call that proximal atrophy. We see some tortuosity, multiple areas of tortuosity. We see cystic deformities of acini right there, and then next to the gland right there. Yep, cystic deformities. So obviously, and then we can go to the left, like a fourth or fifth gland in from the left, further left. Yeah, though, and right there. So there's a number of abnormalities here, all showing atrophic change. Sometimes we just see the little cyst forming, which is an early change. But again, this patient has significant MGD, and so this is, the Meibography is helpful to identify structural change, both early and more advanced. Again, this is a frame from a video Meibography. I like the video because the video shows context. If I'm holding the lid in a way that changes the shape of the gland, that's not good. And if I do a video, I know if I've done that, I can adjust my hold. Whereas if you just do a still shot, you can't do that. You don't know if you've imparted undue pressure, creating an artifact. So Meibography is for structural abnormalities of the Meibomian gland to identify those.
all right.
So confocal microscopy, we've talked about it already, and so here's Claire at the confocal microscope, and again, if we zoom in on the confocal images. So we see these ridges at clearly in right number of ridges. These are fascinating images, and these we have reported last year as um, as structures that are in continuity with the ductal epithelium and ductal and basement membrane. And as we're going to have to show the next slide, whereas if we follow this, if we follow these ridges, and let's zoom in on B actually, as we follow these images, as we go deeper and deeper, we find, let's scroll to the left, the other direction. Yeah, so here, right there, good. So B, the first image in row B, is superficial, only 10 microns deep. The second image is 33 microns deep, and we're starting to see these ridges, these round floret-like images, these structures. But watch what happens as we go to 41 microns deep. These round florets images start to ovalize, become oval, and flatten out. And as we go to 49 microns deep, look at what's happening. They merge, they fuse, and they develop the basal epithelium and basement membrane. So important.
And that's the scar tissue that's
No, no,
forming?
no, 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 no.
What?
Those are your basal epithelium and basement membrane. Those that is the germinative layer. That is the cell layer that is the youthful layer. So in other words, with skin, if you exfoliate your skin, you exfoliate the superficial senescent cells, and the underlying cells, the youthful cells, the young cells that are proliferative and have capacity to to give you that youthful glow. That was your basal epithelium. So
So this is post probing
no,
underneath.
no, 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 no. This is normal. These are normal structures. What we're showing here is how these ridges are essential for the health of the meibomian gland. As we're going deeper in the meibomian gland, what we're showing here, we made this discovery, reported last year. The ridges, as we go deeper, are the ones that either are in continuity with the powerful basal epithelium and basal membrane, or they differentiate into the basal epithelium and basal membrane. All right.
Okay.
I personally think they differentiate into the basal epithelium and basal membrane. And that's important because the health of those ridges or I should say, correlates with your gland area and your number of acini per gland.
Okay.
Very important. So as we go to, you're at 49. If we go to the right, you're at 61 now. You can see how beautiful the basement membrane is formed from those ridges. So this is a healthy meibomian gland. This may or have MGD. That's not the point. The point is that what we reported last year, our discovery we reported is that is the key uh, function of these ridges in the healthy meibomian gland. Okay. So all right, next slide. Let's see. So this is confocal microscopy. So confocal microscopy is important because number one, it shows scar tissue. We showed you earlier tonight. It shows inflammation. We didn't particularly show you that, but it shows presence of inflammation. Number three, it shows the health of your ridges, those orifice ridges. Okay, so these are very important. And number four, it also shows the effect of probing, how it increased duct wall thickness, increases lumen size. All these things we can confirm is happening. We can identify if there's any deficiency or abnormality of it. All very important.
So
Also,
it's basically a very strong microscope that looks down into through the lid orifice down into the gland, and that's what this is. That's what we're looking at right now.
so yeah, that's right. The confocal microscope gives us the ability to do like a biopsy, a superficial biopsy without removing any tissue. And
Okay.
that's what we're looking at, a biopsy of the meibomian gland um, distal duct without removing any tissue.
Okay.
So the other thing is we're going to report next year, but we found a significant association between healthy ridges with advanced atrophy of the meibomian gland on Meibography. So again, that's yet another okay. That's another area where the confocal microscope is very useful. Now, we talked about healthy ridges and abnormal ridges. We didn't show you abnormal ridges, but here on this composite, we show in A, composite A above, there's a Meibography above, which shows, for the most part, healthy meibomian glands. and that correlates with the ridges seen in A. If we zoom in, we can get a better, we can show that a little better. And okay, so there are ridges there, and there's a well demarcated basement membrane. Okay, okay, and basal epithelium, very well visualized there. Okay, now in B, look at B. B is, and I should say, there's also a well-established lumen in A as well. In B, okay, there's a patient that comes from Canada to see us, and marked loss of gland tissue. She's, essentially 99% or more lost gland tissue, but she has orifices. Now, in the right part of B, this is a typical orifice for her. This is a typical distal meibomian gland for her. You can see there's really no healthy basement membrane there. There's no clear basal epithelium. The lumen is not even visible. It's closed off. But this is how she presented, and she was obviously she was in great pain, suicidal, doing poorly, has a young boy, and she came to us like this. And I'm happy to report, and she was on like 3 or 4 different medications, anti-anxiety, antidepressant medications. I'm happy to report she's doing very well now, by following the concepts we talked about, probing for meibomian gland disease, identifying and treating with targeted therapy or comorbidities. So, and now she has her glands. When she first came, she had 1 or 2 maybe per lid glands that were expressible. Now she's in the teens, each lid in the teens, and her her symptoms have improved to the point she was able to stop all her antidepressant medication and her anti-anxiety medication. So it's a real success story. In fact, her story is going to be presented by a doctor I work with in Canada. She's going to present this patient on a poster format at the optometric meeting coming up in Boston in the next month, I think.
Wow, that's amazing.
So a very exciting case.
17 or plus, you gotta repeat that. How many per lid is now expressing Meibom?
She's in the teens. I can't recall exactly,
Okay.
but she's come a long way, and so we're very excited for her.
All
And so
right.
patients ask me, sometimes they email me, I have no glands visible on my Meibography. Remember, we talked about this earlier tonight. If you have orifices, that means there's some likely to be, well, if you have orifices, then there's a duct. If there's a duct, there's likely to be some, beautiful. Thank you, Claire. If they're like we see in this is a paper from a paper in, I think, 219 I published. If there's an orifice as a duct, and we show that here, look at the whole gland atrophy in A, and you can see the duct. You zoom in on that, you can see the duct inside the probe inside the duct here. Okay, I've kind of placed a black line next to it so you can just see the length of the probe. That probe is inside the central duct of basically an atrophic gland. You don't see any gland tissue, but it's there, and because there's an orifice there. If there's an orifice, there's a duct. If there's a duct, there very well may be, often is, if not usually, acid epithelium, not sufficient enough to them to see it on Meibography, but sufficient enough to make oil. Very important. And again, B is again another example of this.
Would you find the same with Accutane users?
Well, Accutane will cause involution of the meibomian glands. So you could get to a point like this. And Accutane's more of a, because it's a systemic medication, it typically affects all the glands similarly. In this case, you can see the variability from gland to gland. So this would not likely be an Accutane case, but the response is the same, meaning Accutane patients do very well with the approach as we've outlined tonight.
Okay,
Very well.
that's great. Okay, so we want to go into, so we understand. Excuse me. We understand the 2 procedures of testing that we spoke about tonight: the infrared meibography and the confocal microscopy. And that's kind of only touching on the beginning of the testing. which we will have follow-ups in our next. We'll go into some more of the testing. We could do some question and answers, Doc, if you're open to that.
Yes, absolutely.
Some of them are going to be repetitive as to we kind of already answered, but if you want to just give a quick, how do we determine what's causing dry eye? Hub and wheel, I would assume, right?
Uh, yeah, that's right. The hub and the wheel lays out the perspective, the approach. Um, Meibomian glands are classically part of this picture of the etiologies, we say, or the causes. Again, over 85% of dry eye cases or irritated eye cases, the Meibomian glands are the key player in that. Uh, but again, the work doesn't stop there. Those patients that have had, you mentioned earlier, had probing, they're not doing well. They need a real robust evaluation. They need a rigorous evaluation to identify those comorbidities. Inevitably, there's something there that's being missed, uh, and so that's very important. But the hub and the wheel illustration is a guideline to start how to start thinking about it's MGD plus. I need to know the severity of my MGD. I need to probe those glands, and the plus part is the comorbidities. But that illustration lays down a number of comorbidities. And I also recommend my book, which was published in 2022. My co-author is a previous patient of mine. Her name is Natalia. She started a not a dry eye foundation. Matt's a part on the board. And that foundation, Not a Dry Eye Foundation, is mission is to help people that are suffering, help guiding them to find answers to what's causing their problem, their pain, their suffering. Uh, Both Matt, Natalia, and other board members. Shelly's another board member. These folks know very well what it's like to deal with this disease. They've been through it, and they've battled it, and now they're in control of their lives, and their eyes are comfortable. Natalia was my co-author on the book in 2022, and one entire chapter is her journey, where she went from considering putting forks in her eyes and twisting them and removing them, or just flat out suicide, despite looking everywhere for help until she found me, my concepts, my approach to this disease. And now she's on a PhD track, in addition to having written a book. So good for her. We're proud of her. And again, she and the others at Not a Dry Eye Foundation are there to help people that are suffering, and they need to speak to other support members. They're there to help. A little shout out there for you guys.
Yeah, thanks.
You do such important work.
I found what I've done with the book is I probably saw a dozen doctors before finding Dr. Maskin, and what I did after finding Dr. Maskin is I mailed all of my past doctors, his book to try to help them learn and to be able to treat people better. Because typically every doctor I saw was medication and IPLs, which didn't do anything for me. It kind of just hurt me. So that's what I do with Dr. Massin's book. It's really simple on Amazon to get it, and I would just send it to their address. And a lot of them actually followed up with me and thanked me.
And the other thing that's important is that's also available on Audible.
Yeah, that is important. Yep.
So that's very important to access. Some patients obviously they can't read, they can't open their eyes, they can't read, so it's available on audio as well.
All right, I'm going to go into some other questions. Any help with chronic chalazion, approximately 8 months after anything besides surgery? I'm desperate.
What I typically for chronic chalazion, number one, again, you have to identify the comorbidities because there's a reason why the glands got obstructed, the reason why the glands got obstructed and developed the chalazion. So you have to identify the comorbidities and treat them. Having said that, the chalazion itself responds beautifully to intraglandular Kenalog, or basically a steroid injection. And I found that worked very, very successful with chronic chalazion or hordeolum, which is a more of acute cause of that swollen or nodularity of the lid. And that's far better than to make an incision in the lid. When you make an incision in the lid, a surgical incision, obviously you leave that irregular contour of the lining of the lid if you do it from the inner aspect. But ultimately, if you inject Kenalog or a longer acting steroid, that does a very, very good job. And that's my preferred approach. But again, if you don't manage the comorbidities, you'll just keep getting them back.
A question about Demodex. How is that treated? What's the best course of treatment?
So Demodex, there have been a number of treatments over the years. I prefer ivermectin, a compounded ophthalmic ointment, ivermectin. There's a drop called Extemvi that is also available. I personally have every case of Demodex that I've treated has been eradicated. The Demodex has been eradicated with the ivermectin topical. So I prefer to do that. I think it's a lot easier for the patient, and it's very successful, less expensive too.
Uh, okay, let's see. Oh yeah, here's an odd one. Why did my doctor only image my lower lids on a Meibography?
I don't agree with that. I think all lids should be imaged on my biography because this disease is progressive if not managed successfully. Um, your upper lids one day may wind up being the only lids with intact or functioning glands. I prefer to salvage every single gland I can. Okay. I don't know what I'll be left with in 10 years from now, 20 years from now. To do that properly, the upper lids must be imaged as well. So you know what's going on with the upper lids. It's not just a lower lid issue. Okay. You have Meibomian. If you have Meibomian MGD in the lower lids, you have them in the upper lids as well. And the right approach is to work to preserve each of your Meibomian glands.
Yeah, there was a doctor who had just probed the lowers. I was talking to a person. He said, "No, I only need it on my lowers," and I disagreed with that as well. Another big question out there is a case of mild MGD. Why would I be probed?
Well, because all mild dry eye eventually will become moderate and ultimately severe dry eye. It's progressive disease. And not just that, MGD is classic for being asymptomatic while you lose gland tissue until you lose sufficient gland tissue or develop other comorbidities where now you're you're miserable. Now you're clinical. Now you're symptomatic. So I I probed a 9-year-old a few months ago that was already showing atrophic changes on the meibomian glands. Uh, we cannot, and we're seeing that a lot. In fact, recent publications, young people, preteens getting meibomian gland atrophy. You have mild meibomian gland dysfunction. You don't want it to progress. Probe your glands, identify your comorbidities. You don't stop it in its tracks and stay healthy before it gets to the point where you have to be, resuscitated or rescued, so to speak.
Right. Here's an interesting one that I could probably answer is what happens when the doctor can clearly see the duct but can't get the probe through it?
Important
Rookie?
thing. Go ahead.
A rookie? No. Okay.
No, it should all probing should start with a 1 millimeter length probe. The 1 millimeter is the shortest and stiffest and most likely to find the entry angle into that gland orifice. And then you can do longer probes if indicated. Uh, some do not start with a 2 millimeter or 4 millimeter probe because they're likely to bend and not get in the gland. Very important concept. If you have it, and if you have a densely scarred orifice that you cannot get through with a 1 millimeter probe, then I have what's called a dilator probe to get through those individual glands that are particularly difficult.
Okay. Does Sjogren's attack meibomian glands? If so, where?
Uh, yes, Sjogren's leads off most times to reduced aqueous tear. So you have aqueous tear deficiency, and that's a major comorbidity to meibomian gland um, dysfunction. Developing basically inflammation, and then within the inflammation, you develop the periductal fibrosis and gland atrophy. Secondly, Of course, Sjogren's disease is emblematic of an autoimmune disease. An autoimmune disease can attack any part of the gland. It's been shown some time ago that there are antigens surrounding the gland that may be a site of attack for autoimmunity or autoimmune diseases. So, in a couple different ways, Sjogren's can, and again, is associated with meibomian gland dysfunction. They really go hand in hand.
Yeah. Um, Another question is on eye pain, NC. Help me with that. NC, neuropathic.
Oh, neuropathic pain.
Yeah.
All right, so there's a diagnosis of corneal neuropathic pain that's out there. I personally have a different approach to managing that disease. Whereas many, people use, serum drops and steroid, and then if that doesn't help, gabapentin and low dose naltrexone and so on. My approach is different. It turns out my approach that I've talked about tonight by probing the meibomian glands and identifying and treating the comorbid disease works beautifully in neuropathic pain. It turns out the neuropathic pain oftentimes actually can be emanated from the meibomian glands, which is why when you put topical numbing drops on the patient who's been diagnosed with neuropathic pain and the pain persists, rather than diagnosing neuropathic pain whereby the nerves are felt to be autonomously firing, it turns out that the meibomian glands are the cause because topical drops and numbing drops do not numb the meibomian glands. So you put topical drops in an eye that's been diagnosed with neuropathic pain, the pain persists. One possible reason is the meibomian glands, which are not numbed by those topical numbing drops. So we've had great success in managing neuropathic pain. Published a paper on it with a case series in the American Journal of Ophthalmology a few years ago. And I encourage anyone with neuropathic pain to not give up. There's actually solutions. I think that, no one can guarantee anything, but what I'm saying is that we have a lot of experience, a lot of success in managing this disease, neuropathic pain, by identifying in a rigorous fashion all comorbidities and ensuring that all comorbidities are identified and adequately treated in addition to probing the meibomian glands. Sometimes those glands need to be probed at a deeper level, okay, because again, that may be in some cases the cause of that pain. So there's a reason for why the pain's existing. We're having great success. So I would suggest an alternative approach and not just give up and be put on a lot, systemic medication that could actually exacerbate the dry eye issues.
Yeah, I went that route in the early days. Somebody was pumping me full of gabapentin, like a lot of capsules. God, I couldn't even feel myself think. I was just completely out of it. I couldn't run my business. I couldn't function. Had a tremendous side effect for me.
It also could increase suicidal thoughts, those medications.
And you sure
Natalia,
don't need that with
Natalia
this
was put on it.
disease.
She almost fell down her stairwell, because it can affect your level of sensory capabilities and can
Right.
create new problems. So there's a better, in my experience, is a better way.
Agreed. Uh, what are Dr. Maskin's views on amniotic membrane treatment?
I prefer amniotic membrane treatment in cases of chalasis. I use it as a graft. I found it not necessary to use it as a like as a piece of amniotic membrane. Sometimes people use it like a procara, a piece of amniotic membrane to put on the ocular surface. I have not found a need for that, but I do use amniotic membrane as a graft when I want to remove a lesion from the surface of the eye, like chalasis, or maybe a cancer or precancer. Um, I find there's a great use for that in those settings. It works beautifully because it has intrinsic anti-inflammatory properties. It suppresses scar tissue. At the same time, it's nutrient dense, so it actually stimulates the proliferation of the neighboring cells, which will grow over the amniotic membrane, leaving a nice smooth surface, which is what we want to accomplish, say, at chalasis surgery. So it's very effective. It's done in all patients. Whether I noticed a question about patients who've had LASIK versus non-LASIK patients, and it's the approach is the same. The existence of LASIK doesn't affect the approach to handling countertopic chalasis. the existence of the existence of LASIK does increase my or I should say, it does raise the issues of aqueous tear deficiency and blink abnormalities that occur due to the LASIK procedure. So again, those are just comorbidities that also need to be attended to.
What are the most common comorbidities that you come across in your practice?
Well, allergy and aqueous tear deficiency are probably the two most common, but I mean there are many others as well. And um, and so again, what I stress is identifying the comorbid condition and adequately and targeting it with the appropriate therapy. Um, and those are the keys. You identify it and then you target it to reverse the comorbidity.
Okay.
Leads to success.
This is probably a quick one. How do you protect the cornea during probing procedure?
I put a bandaged contact lens on there, but also in addition, patient is numb and comfortable because if the patient's not comfortable, then they're going to be squirming. They're not comfortable. You're not going to get as effective a probing procedure if the patient's uncomfortable. So initially, I developed the jojoba anesthetic ointment, which works beautifully in many patients. But some patients, particularly early on, when they first present with this disease and they need the probing, they're very delicate. And if you don't numb it adequately, I like to put lidocaine in the brow, what's called a supraorbital nerve block, and then in the top of the cheekbone for an infraorbital nerve block to let me probe, in a well-tolerated fashion, both upper and lower glands. But if the patient's not comfortable, then you're not going to be able to get as effective a probing procedure, and you have to do it more piecemeal. You may have to only do like 10 glands at a time until you have the whole lid done. So you may have to have the patient come back every few days until you have the entire lid done. Once that's done the first time, then in follow up, it's easier for the patient. So some patients may say, once you've released that scar tissue the first time, treat their comorbidities, they may come back, for their next probing. They may not need that level of anesthesia, or they may say that was great. Let's do the same thing. But typically, once that initial probing procedure is done, then things are easier the next go round. They know what to expect and so forth. The other thing that can be done in patients that need probing to reduce anxiety is hold off on the caffeine for a few days before you're probing. Hold off on the caffeine. Maybe some patients will take a medication to relax them beforehand. And there are different ways to do it, but it's important to have the patient comfortable when they have the procedure to
Okay.
get the best results.
Uh, I have one here. Please talk about conjunctival chalasis and its impact on symptoms. Will symptoms persist after probing? And if so, will they resolve after recision surgery?
Uh, well, yeah, conjunctival chalasis is important. I break it down into usually superior chalasis and inferior chalasis. Superior chalasis oftentimes leads to mechanical friction as the eyelid, rather than gliding over the surface of the eye, catches on those pleats or those folds of that loose conjunctival tissue on the top of the eyeball. And that creates inflammation. Again, inflammation, as we know, can lead to periductal fibrosis. There's inferior chalasis, which typically is located in the infratemporal part of the lower lid. So the tissue is inferiorly and it rests on the lid margin, more often in the outer corner, but it can be across the entire lower lid margin. The tissue just sits there on top of the lid margin because, again, the conjunctiva is kind of floppy and loose, not well attached to adherent to the eyeball. And that creates symptoms like foreign body sensation. That can create symptoms like heaviness and tiredness of the eye. That could channel the tears rather than the normal flow across the surface of the eye toward the nose. It can channel the tears to the outer corner of the eye, so then you have some moisture in the outer corner. So, uh, and so that no, I really emphasize targeted treatment for each comorbidity. So the treatment for that is specific to the chalasis. Probing is not going to impact chalasis at all. Probing is going to restore the integrity of the meibomian glands. It's going to release the scar tissue. It's going to activate your stem cells, but it's not going to affect aqueous tear deficiency, allergy, Demodex. It's not going to impact chalasis. Every comorbidity has a specific targeted approach to efficiently and effectively reverse its symptoms,
Right.
probing its meibomian glands.
Okay. Do your glands continue to improve with each probing?
Uh, I would say the glands improve from the very first probing, and they are maintained with subsequent annual probing. Um, as you may remember from that, we looked at it over a year. So the peak duct wall thickness and lumen area increases. It peaks at 1 to 3 months, extends to approximately a year, although it comes back toward baseline, but still is over baseline. So what happens is we repeat that cycle. All right, so that way you keep the glands healthy, uh, and so the patients do well. Our research is focusing on taking it to the next level because ultimately, as I mentioned before, our goal is to restore a full complement of healthy meibomian glands within the lid, a full population of healthy meibomian glands. So the meibography would be restored with healthy meibomian glands, and that's part of our research. We know the probing again activates stem cells, um, increase the duct wall thickness, and so forth. And we know we can see some evidence on 40% of the lid that we probe, but again, we're looking to further improve upon that.
Okay. Here's another one. If two people have MGD with restricted glands, why do they not display the same symptoms? E.g., one patient may have burning and gritty feeling, and the other may have irritation, itchy, and blurry vision.
Right? And that is due to the comorbid diseases. So one person may have aqueous tear deficiency along with their MGD, other patient may not. Other patient may have allergy. So remember, the purpose of probing is to restore the integrity of the outflow tract by releasing the scar tissue. It also activates stem cells, but it's not designed to treat allergy, Demodex, and so forth, the other comorbidities, which, if left undiagnosed or inadequately treated, will cause the scar tissue to come back on the meibomian glands. So the probing is your initial point, the initial the beginning of taking control of the disease by restoring the integrity of those glands that have been lost due to the inflammation from these comorbidities. That's what probing is for, and it works. It does very obviously does very well in that with that.
All right. Uh, where are we here? Other questions? I think we wrapped up a lot of them. Most of them, a lot of them are very repetitious on what we've already established and what we've already spoken about. So there's no sense.
Right.
Uh, Image my lower. What is the best way to treat my Meibomian glands? I mean, here's one we kind of answered, but maybe you have something to add. If a gland is not yet atrophied, is there a way to make it healthier or help it grow? IRM plus IVCM regeneration figure. Oh, that's for Claire. Yeah. Yeah. Sorry. You have anything to add to that? We kind of covered that.
But yeah, it's this, basically it's the pro. It's funny because sometimes people say, how come what you do, you offer probing and a comorbidity, but you don't offer some of these other procedures that they hear about, and uh, and the answer is this: what I do is very targeted. The meibomian gland has scar tissue, I release it. Okay, if it's allergy, I target it specifically. Aqueous tear deficient, I target it. So in other words, the analogy is if I've got appendicitis, I'm going to take out the appendix. I'm not going to take out the gallbladder. It's very targeted. And there is an array of different treatments out there. What I've found is sticking with the basics by targeting what's wrong efficiently and effectively and safely restores comfort to the eyes and restores lives. So it's important to recognize that not to get defocused or distracted from the root cause of the problem. Because by treating specifically using target therapies, you can reverse the root cause and get comfort back again. Don't get not to get distracted with so many different. It's a bewildering array of treatments that are being offered. And again, I I've when I stick with the basics, and it worked beautifully. It's worked beautifully for 20 years since I developed probing.
I Googled something the other day on dry eye, and somehow it goes to my phone, and all of a sudden on my Facebook, I start getting ads on every single device: Steam goggles, this goggle, that goggle, this eye tears, and all of the gimmicky stuff. In my opinion, and there's so much out there. How does one know? And that's the sad
Well,
part.
again, the key is to not get distracted. What's wrong? The glands are blocked. 90% of those glands are blocked with scar tissue. Probe to release them, release the scar tissue, activate your stem cells, and then find your comorbid diseases, target them specifically. Don't get distracted about the bewildering array of of these treatments that it's just that are available, that will again just knock you off course. And it's hard for patients that are suffering because they want to feel better, but sometimes again, if you just stay true to those concepts, what's the proximate cause of the disease, um, what's my comorbidities, and how can I target them rather than shotgunning. You don't want a situation where it's like, oh, let's try this, let's try that, let's try the other thing. Okay, because then you're basically wasting time and money and not getting. It's not a direct path to success, in my opinion.
All right. I have another here. It says, Matt, can you ask about all trans retinoic acid for hyperkeratinization?
Works beautifully. I've used that. Since the 80s. In specific cases, it works beautifully to reduce the keratinization of the lid margin. Very effective.
Okay.
See,
Uh,
again, in tandem with probing, again, it's just it's one of those comorbidities, the hyperkeratinization of the lid margin. It works beautifully. Um, and I have several patients using it effectively and successfully.
okay. Here's one. Have you seen any patients on chemotherapy or immunotherapy who get dry eyes, and what is their usual problem?
Well, it depends upon the chemotherapy, but chemotherapy basically can affect cellular proliferation, and so um, it can affect glandular functioning and so forth. But again, the concepts are the same. Okay, it can create inflammation. The inflammation could cause a scar tissue, and the way to treat that is, as I said, MGD. You probe, you identify the other comorbidities that may exist in the setting of the chemotherapy, and then you treat those those comorbidities with targeted therapies, and you'll do well. Graft versus host disease, another example. I've had a graft where you have bone marrow transplants, and the graft attacks the host, so to speak, and you get inflammation of the lids and my Meibomian glands. Again, probing does well to release that scar tissue.
All right.
Very well.
Uh, let's talk about rosacea, because people are asking that as well. How do you treat rosacea? What is it? What does it do? How does it affect the eyes?
Well, rosacea is a condition, as you know, that uh, is a systemic condition when it affects the skin. And if it does not affect the skin, I don't call it ocular rosacea. If it does not affect the skin of the face, I don't call it ocular rosacea. Um, if you have rosacea of the face, then in my view, then you may have ocular rosacea as well. But ultimately, um, you know, the way I think about rosacea is this systemic condition that is pro-inflammatory. So you already are pro-inflammatory or likely to get inflammatory reaction to even the smallest amount of a comorbid diseases. So you may have a mild comorbid disease when compared to other people without rosacea, but in the setting of rosacea, suddenly it can create significant inflammation. So it's essential to identify the comorbid diseases in that case, and again, to target them. You may also want to look at the foods that one eats and the beverages and so forth, because we know systemically the gastrointestinal tract can exacerbate the rosacea or minimize the effect of rosacea. That's the way to manage that problem.
And what exactly is blepharitis?
It's a blepharitis. The term blepharitis just means inflammation of the lid, so it's not a very specific term. And we typically break it down to anterior blepharitis, which is the involvement of the lashes, most typically where you have crusts or deposits around the lash roots. Posterior blepharitis most often time refers to Meibomian gland dysfunction. So that's a very non-specific term, but that's what it means.
Okay. I have a question, a follow-up on that. Altrans retinic acid, is it over the counter or prescription?
No, no, it's prescription.
It's prescription. Okay. All right.
All right.
Yeah, I think we're doing good. We did good. I think we got a lot of information out there. Um,
Well, we got over 100 people sign up, and that's pretty
okay.
exciting.
All right, good. And everybody's a member of our group. We'd like some feedback on the group on how it's doing. MGD Dry Eye Support Group. See if everybody likes what we're doing, and if they have any suggestions on how we could make it better. I'd like to thank all my fellow dry eye sufferers for all the interesting questions asked tonight. I would especially like to thank you, Dr. Maskin. Oh, and his lovely research assistant, Claire, for dedicating their time and efforts to try and help us. They are some of the best human beings I've met in my dry eye journey. Until next time, everybody stay strong. And if anyone would like to follow up with me, feel free. My email is matt@mc-electric.com. This recording will be available exclusively on his Facebook page for the next month. Probably going to be shared to YouTube afterwards. That had a very big following. I got 2 emails today from people that saw our last on YouTube and gave them. I was talking to both of them for over an hour today, giving them all my experience on what I came across on and my disease, my journey. So if anybody's looking for help, get in touch with me. I'm your first line, and of course, Dr. Maskin's available via email as well. And call his office and buy his book.
And I like to add to that, for everyone that's still listening out there, you will not find a more dedicated patient advocate than this man right here. He goes to Washington, D.C. on your behalf. He spends so much time in helping individuals that are suffering in so many ways. I call him Oscar, after Oscar Schindler. He literally does everything he can to save every person who's been suffering from this disease. Um, I personally am blessed to be in this position to help. I had no idea in 1988 when I began studying Meibomian glands and growing them in the laboratory that I would be here now, having developed this procedure that's been so impactful in helping save not just marriages and people's lives. It's just been like I said, I just feel blessed to be in this position. I want to again with Matt. I know we want to extend. The importance of hope. There's no reason not to be hopeful. The challenge is logistics. That's really the challenge. Hope is there. We see it constantly again and again. The challenge is logistics, how to get the care you need when you need it at the right, and that's the challenge. It's logistics, not so much what to do. What to do just requires a rigorous evaluation and management of the problem. It's logistics, how to make it happen. So keep the hope. May not be able to access the care today, but there's tomorrow. Okay, very important. There is effective, efficient, safe treatment for you. So keep that hope, Matt. Again, it's a pleasure and honor to work alongside of you to help these people that have been suffering. So,
Thank you, Dr. Maskin. All
and
right. Good
Claire,
night,
thank you over
everybody.
there as well.
All right. All right. Good night.
All right. Good night, everybody.